for this training session on employing inhibitory learning as part of exposure. By way of introduction, if you don't know me, I'm Dean McKay. I've been at Fordham University now for 27 years, and my research for all of that time has been in the anxiety disorders, OCD, and more recently in efforts at disseminating good treatment practices and a bit of policy work related to that. If you're also familiar with some of my stuff in the past, I also have spent a lot of time thinking about disgust and other emotional states that might promote avoidance, and also to varying degrees lately also misophonia. We won't end up discussing misophonia today. I want to talk more about this particular procedure, inhibitory learning. So probably a lot of you have heard about inhibitory learning. It's been around as something people have been discussing as a method of employing exposure for some time now. Mainly like in the last 8 or 9 years, it's gotten a lot more attention. But if you've been a psychologist or a therapist for any period of time, you know that there is a long lag between things making it out into the specialist community and then getting translated into more everyday practice. And so the aim here is to really introduce you to this as a contrast with the original exposure model that most people have been trained in. And then I have a couple of illustrative examples. So let's get started here. So here's my little overview of our training today. It's a review. We'll review briefly the classic exposure model for anxiety and avoidance reduction. I'll introduce the inhibitory learning model that has been recently discussed in the literature. There are 8 broad means for anxiety and avoidance reduction with the inhibitory learning model. We'll go through those and we'll have some illustrative examples that are very brief in nature as we go along. And then I have 2 case illustrations towards the end that will sort of tie it all together to varying degrees. And then we'll have some question and answer at the end. So there will be plenty of time for us to discuss some of these details and applications. Okay, so as a little reminder, the majority of contemporary exposure models that we have are reliant on the conceptualization by Foa and Kozak. I don't have a lot of references committed to memory in their totality, but the Foa and Kozak one is certainly among them, published in Psych Bulletin in 1986. It's pages 20 to 35 in volume 99. It cited that frequently. And the central basis of this model is that in order for exposure to be effective, the clinician has to present whatever the target stimuli are at a sufficient intensity, as they put it, to engage the fear structure. So it's inherently a neuroscience-based fear reduction model, which is sensible given that Pavlov was also really more interested in the neural connections that undergird conditioned stimuli. And so the central mechanism that they hypothesized is that habituation and, as they emphasized, corrective learning would come through change in those memory information structures. So it requires, as part of any session, real physiological activation. In fact, in that article, there's an interesting piece, and it'll be something that'll be a topic of discussion in a future training, actually. But they talk about how that is so essential that you have to do everything in your power to ensure physiological arousal, even if the client engages in some strategic effort to minimize it. And they give this beautiful example of a client who's contamination fearful, who has a little bit of urine put on their arm. And upon receiving that, their skin response goes very high, consistent with the expected anxiety reaction. And then it suddenly drops. And when asked, the client said, well, I knew exactly where it was, and therefore I could wash it off, and so I no longer felt fear. It's things like that that, in the view of Foa and Kozak, the clinician was mandated to get around if they wanted to promote any change. And furthermore, the tightrope that clinicians have to walk is that exposure that might be too intense can have adverse consequences through sensitization. So what they mean by that is the fear structures have a further consolidation. They get further ingrained. For those of you attending, if you're into neural networks, the notion is that you form a deeper groove in that neural net that basically forms a stronger memory. So this is one of the few treatments where at outset, the theory has a place for possible worsening. As an aside, psychology and other theoreticians have not necessarily emphasized the potential harmful effects. If you look in the research literature, there's not a lot on treatment harms, but it is something of interest, and this is one of the few places where that could actually happen in the course of therapy. So if we had to put it into a schematic, here are the key things that you might do. You'd have, on the one side, you identify a target set of stimuli. There would be in vivo exposure. Remember, the research literature emphasizes that in vivo exposure, live exposure, is going to be more desirable. You can ensure better outcome if that in vivo exposure is accompanied by some kind of imagery, and also that you elicit physiological arousal. So those three things, that's the tripartite, the hat trick, if you will, for any exposure session in order to facilitate change in those information structures. And imagery is a little bit of a different skill that clinicians need to bring to bear when it comes to putting together effective treatment. And it will be actually the topic of a future training. So just FYI, keep your eyes out for a separate training on imagery. Some of you who know me, a little sidebar, if you don't mind indulging me for a moment. The way I got involved in a lot of this work is because I was told that I'm very good at getting images into people's heads a little bit against their will. And I've thought deeply about this, and I would like to facilitate training others to be able to do the same. You can entertain your friends at parties with a skill that I would like to be able to convey on a future training. So, keep an eye out for that. In the meantime, though, coming back to the Foe and Kozak model, this has been the framework that has been really the dominant way of conceptualizing anxiety reduction now for close to 40 years. And with that has come a little bit of a reputation that we could use to help explain why some people feel hesitant about doing exposure. Because think about the way that this unfolds. Client comes into your office, and if you follow the FOA and Kozak model strictly and to the letter, that would mean when they enter the office, your task for every session is to elicit anxiety at a fairly high level, just high enough that you engage that fear structure and then have it habituate. Now, the reason why I'm highlighting it in that way is let's think about your engagement with pretty much any other healthcare professional. I like to use as an example going to the dentist. For a while, I was dental fearful. I'll be self-disclosing with you. Some of you who know me well know that this is a true thing. I used to really have some concerns about going to the dentist. And imagine if every time you went to the dentist, you didn't get Novocaine. Imagine for a moment that the dentist said, we don't have Novocaine, and instead we're just going to drill. And you're going to have to come back several times because this filling is fairly deep, and you may need to have other fillings taken care of. You have other cavities, but we can't give you Novocaine. So you'll feel relief. I can assure you there will be relief, but it's going to really hurt when you come into the office. Now, you might go once, but the willingness and ability to do that more frequently for the average dental patient is going to drop pretty low. And there's a very good reason, therefore, for why we have things like Novocaine. Well, in that spirit, imagine then not only with your adult clients who might be fearful, but picture that you're doing this with children. As I tell my students, if you were to do that as an everyday clinician, you can be assured of having a lot of free time on your hands. And so, the Foe and Kozak model on paper is exactly in line with a particular approach that would be advocated by Pavlov. And even if you follow hierarchy, you're nonetheless going to be potentially running into a real challenge in everyday implementation. So the inhibitory learning model helps to kind of address this issue. And also, I would argue that, whereas treatment is efficacious with exposure treatment based therapy, we see large effect sizes in numerable studies across different complexities of symptom presentations and diagnoses. And that treatment dropout is not significantly different from other treatments in the case of PTSD, for example, or in OCD, two conditions where the reputation is, at least in the popular eye, is that exposure increases the risk of people bailing on treatment. The other side of this is that I don't believe that actually most clinicians do the treatment the way Foe and Kozak articulated. And let me illustrate why I say that. Given what I just said before, clinicians are expected to follow this approach. And whether or not they've actually done this, I think we can say is not necessarily true. I have a few quotes that are illustrative about this, and I also have an anecdotal illustration. So exposure practice exercises designed to teach the child, so Bruce Tropita is a child-oriented anxiety specialist, through reasoning and experience that their anxiety is not necessary or is out of proportion to the perceived danger. Well, that's not how I understand the Foe and Kozak model, right? If the Foe and Kozak model emphasizes eliciting anxiety, your role as a clinician is not to provide additional verbal information that might diminish the intensity of that experience. In Ahmed and Westra, they talk about specific instructions for expectation for change and tolerance of anxiety as palliative additions to exposure. Again, not in line with how we have come to understand the Foe and Kozak model, which has been the dominant perspective. Now, in addition to that, if you think about those of you who are on this training who routinely deliver exposure, and think about how you do it every day, and whether or not you are consistently and persistently watching for the elicitation of anxiety, the reality is probably rather different. And so one of the things I've said, and I don't know that I could really say that I coined this phrase, but I think it's an accurate conveyance, is that the inhibitory learning model, I believe, is actually the clinician's model of exposure. And what's nice now in our discussion today is that we will bring formally to bear the framework that I think that most people already implicitly do, at least if you're good at doing exposure and you get clients to return to your office after that first session. Okay, so here are a couple of things just to kind of think about as to why that clinician's model is an applicable term. So first of all, the primary learning mechanism. So according to Krask, and Michelle Krask, I think, wrote what is perhaps the nicest and clearest summary of the inhibitory learning model that can be used by clinicians. And so mainly the emphasis in exposure is that you are developing new learned connections for behaviors to compete with the old ones that are part of the feared circuitry. So in that regard, the inhibitory learning model is also consistent with original Pavlovian notions. Pavlov, when describing the process of conditioned stimuli, and by extension, the process by which a conditioned stimulus no longer elicits a conditioned response, one of the things he talked about was that connection never goes away. The concept of extinction in our current thinking is not germane. There is no longer a notion of extinction. The idea is habituation is that conditioned stimulus no longer has the potency of connection with the conditioned response, but instead new learning forms that competes with that old conditioned stimulus relationship. So that notion is an important one to keep in mind, because that's what kind of is the through line for all of the inhibitory learning strategies that we're about to go through. So it's great to know that, because it changes now our relationship with fear elicitation in the practice of exposure. And I guess to be balanced about this, we should not be concerned necessarily with whether or not we elicit fear in our clients, but just know that you are not required to. That's the kind of issue that we should keep in mind. All right. Okay. So the routes to inhibitory learning. So this is a little like foreshadowing. Here are the various elements of inhibitory learning that we are going to approach. So one is expectancy violations. There's elimination of safety cues. There's exposure in multiple contexts. There's a concept called affect labeling. There's variable exposure along the hierarchy, deepened extinction, reconsolidation, and occasionally reinforced extinction. So each one of these form broadly strategies for addressing different aspects of inhibitory learning methodologies. So let's start with really what is my favorite one, expectancy violations. So in expectancy violations, the idea is that, excuse me, you have some target stimulus that you are using to produce exposure, right? So in typical exposure-based treatment, you come up with the situation for which you're going to practice. The client has an anticipated outcome. Now, what is interesting with this, and I'm not going to go too deep into the weeds on cognitive processing, but modern classical conditioning has these elements that look a lot like cognition. And here it is right away, expectancy violation. So the individual is forming a prediction. The basis for this, if you're like kind of a historian of psychology, if you will, you could check out the animal behavior literature from 1972, summarized nicely in an article by Robert Bowles. And interestingly, this aspect of expectancy violations was actually demonstrated in a publication by Foa and her group in the late 70s. So it's interesting, 9 years prior to Foa and Kozak's formal model indicating that you must elicit fear during exposure, Foa also showed that in controlled settings, you can do exposure where you don't elicit fear. I'm going to describe that in just a second. But basically, the idea here is that when doing exposure with an anticipated outcome, if you ask the client beforehand, hey, how anxious or how much distress do you expect to feel for this thing that we're about to do? The client will tell you, right, that they're offering a prediction. The individual is saying, here's what level of distress I expect to feel. Now you actually do it, but you set the stage as a clinician in such a way that the actual outcome, the emotional experience, is rather different. Now, as I'm describing this, probably a lot of you can resonate to occasions where you've done exposure and maybe rather than feeling fear, the client feels a range of other emotional states. They may feel relief. Maybe they laugh and find it humorous. Perhaps they experience nothing. Maybe they even, if not feeling the level of fear they predicted, they feel something quite a bit less. And so all of those collectively would be part of expectancy violations. Now, for you as the clinician, you can facilitate that. You can say things, remember imagery, you could say things that enhance the exposure to the situation, but that run counter to the prediction. So you can elicit different emotional states through your own imagery evocation as part of this practice. So expectancy violations, in my view, personally, this is the one that's great to really know about, if nothing else. So of all the other ones that we're going to do today, expectancy violations is the one that, for me at least, is very dominant and comes up very frequently, partly because the imagery facet, it leaves a lot of room for provoking a wide range of emotional states. So if we use a few examples, well, actually, before I go back for a second, the FOA paper, she describes people who came to the lab who had rat fear, and the exposure was in images, not with live rats, but where some of the images for exposure were fear eliciting. So actual rats in their natural habitat. And then other stimuli involved rats, but in like pretty settings, like, you know, in a floral area or in some setting where, you know, it would elicit some kind of mix of the reaction to the rodent in conjunction with things that would be pleasing. And it turned out that those situations where the rat was presented in situations that were appealing produced fear reduction. So you don't need to elicit it. If we use a few more examples, you could do this kind of thing, contamination fear. It's disarming for clients who might have problems with dirt to then go out and see flowers, but also handle the dirt. Social anxiety, I've done this one with clients. So the concern about blushing is a specific kind of manifestation of social anxiety, incidentally. And you can have circumstances where you elicit that kind of rosy cheek reaction, but then while doing that, comment on how the rosacea that they have on their face is very complementary to their hair color. It's kind of like a little off, it's a bit of an offset. So rather than commenting on, oh, wow, you must be embarrassed, and say like, oh, wow, look at that. It's like you have foundation on that's very complementary to your hairstyle. Panic, if you have someone engage in interoceptive exposure, but they're exercising. So exercising would elicit a whole different set of emotional reactions, especially if the person is accustomed to exercising regularly. And then spider fear. So while they're exposed to spiders, you could talk about how they're doing their part to engage in pest control, which is an interesting kind of alternative way to describe it, because usually when people are fearful of spiders, mostly they're concerned with getting bitten. So we're going to, by the way, review all of these again near the end. So second one on our list of inhibitory learning strategies, occasionally reinforced extinction. In this particular approach, the idea is that the person has some kind of anticipated outcome related to the target stimuli. Occasionally, they get something in the actual outcome that is near to it, not necessarily at the same level, but comes close. And then also they have exposure that is in line with what we showed before. In other words, expectancy violations still happen. They have other reactions to the stimuli, but every now and then something actually does go slightly awry. And so it's important to keep in mind two things with occasionally reinforced extinction. One, you probably have experienced this before with clients. They practice the exposure strategy that you've laid out for them, and they come back to the office and they say, well, yeah, it actually kind of didn't work out the way I thought it would. I had the following bad outcome occur. So you see this sometimes, like let's say with social anxiety. That's a nice illustration, because people who are socially anxious do in fact have social interactions that don't go well periodically, especially early in the going as part of exposure. And so as you're working on this with clients, the anticipated outcome may be one of, considerable embarrassment and maybe considerable social rejection. The actual outcome that you might have practiced with them during session was filled with expectancy violations. And then maybe when they actually were in the situation rehearsing it as part of their homework, they have a partial real outcome that looks similar to the anticipated one. So maybe they get somewhat embarrassed. Maybe someone actually comments, let's say if we use the blushing example, someone says like, oh, hey, it looks like you're uncomfortable, right? So they notice the blushing. They maybe don't reject them for it. They may not call attention to it as intensely, but they nonetheless make a response to it. So that would be in the category of occasionally reinforced extinction. The virtue of this in inhibitory learning is that it helps as the client is working on this, they get better and better at strengthening the alternative response, given that we know in the real world, periodically the conditioned stimulus will be associated with the conditioned response. So those competing neural connections, you want the person to get better and better at one side of it, where they're doing the new behavior successfully, while also recognizing that, yeah, every now and then, this won't go perfectly. It won't go the way that we scripted it in the session. So cautionary note on this one. It's probably a more advanced approach. I listed it second, frankly, because I'm running a bit in parallel to the way some other writers have laid this out. So when you look in the research literature on inhibitory learning, they lay it out in this sequence. But it's also worth knowing that this could come up very early in the course of treatment. So it's better to be prepared for this if you are conceptualizing a case using the inhibitory learning framework, because you may have this happen. In fact, I would argue that it's very likely that it will happen if it hasn't happened to you already. So it's one of these things that's a little bit more of an advanced approach. So whereas it may happen by chance, you can also plan for it a little bit. So these things can happen deliberately. You may do this after processing the majority of the hierarchy. So let's say in the course of treatment, if it never happens, then you may plan for it, because again, you want to consolidate the new learning. You should choose this for things that are genuinely not harmful. I'm going to illustrate that later, but it's an important one to note. And related to that, the local conditions for the clinician and the client values need to be considered in determining what might constitute harmful. So I call attention to a piece that I wrote in the peak of the pandemic around this. So again, little sidebar moment. If you remember early on in the pandemic, and those of you who were practicing early in the pandemic, you may have struggled with how to do exposure for, let's say, contamination fear and other things that required that the client go out in public. And frankly, at the beginning of the pandemic, so early and into mid to late even 2020, a lot of us were kind of struggling with this ourselves. But really, the reality is that we also have to take into consideration a range of factors as to what constitutes a safe exposure activity. And that was something that we addressed in that article. So to illustrate more pointedly, if you were concerned with dirt and germs as a contamination fearful individual, and if you were practicing with going into sheds and other places where there may be a lot of dirt, and you're in the Northeast, well, you could do that pretty easily and know that your client will be fine. And maybe even you would have them do something like sweep in a shed. I remember doing this with a client. I had recommended that they go in their backyard, go into their shed, a place that was, in their view, a particularly contaminated location. Now, on the other hand, if I was a practitioner in, let's say, New Mexico, I might not make that recommendation, because I know that in places like that, the risk related to dried mouse feces is very high, because some of you may not be familiar with this. When I've talked about this in the past, people are unaware of this. There's a virus that you can contract from mouse feces called hantavirus, and it's in the Southwest. And so if you sweep mouse feces, right, there you go. Jennifer knows it in the chat. Hantavirus, which, by the way, hantavirus, it feels like the flu, but it will kill you. So not safe in the Southwest. There are other illustrations of this. So, you might say in Australia, I'm assuming we don't have any people from Australia on the call here, but if we did, or if you're corresponding with people and consulting with folks in Australia, they would probably tell you that spider fear and having occasionally reinforced extinction as part of that, where someone might get bitten by a spider, is a pretty serious hazard in Australia, home to the majority of the deadly to human spiders. So you wouldn't just like stick your hand randomly under a rock. So the local conditions and how you go about doing this need to be taken into consideration. And local conditions include temporally local. So the pandemic, for example, which I'm going to talk about a little bit more later today. Okay, so elimination of safety cues. So safety cues get a lot of attention. Any good exposure process with a client must take into account safety cues. And safety cues include very blunt, obvious ones: the presence of another person, maybe the person carries with them water or Xanax or some other thing that they know they'll never take, but they are able to nevertheless experience the circumstances because they have it handy. Or it could be something subtle. A really subtle one that another colleague alerted me to was someone who was fearful of heights and was building up the hierarchy, and got to a point where they were walking over a bridge with this clinician. And while they're walking over the bridge and they're going higher and higher in the incline to the peak of the bridge, the person has their hand in their pocket and they're rattling some change. And that change rattling was like a safety cue as a reminder that they were still alive and okay. And when the clinician asked the client to take their hands out of the pocket, suddenly their anxiety spiked. And so safety cues are this learned, reinforced, associative stimuli that signals to the client that everything is okay. Now, to be fair, one of the things that's worth knowing is that in cognitive models of treatment, there's a lot of discussion about safety cues and whether or not some judicious inclusion of safety cues can be a facilitator of treatment. From my perspective, safety cues are also something that we've developed for adaptive reasons, right? The idea here is that evolution favors overcorrection. And so anything that we can find that's a signal that we're okay will be most likely learned fairly readily. And our job as clinicians is to make a distinction between the safety cues that the individual has accumulated that are unhelpful versus the safety cues that are probably ones the person would be well placed to keep. And so, like, there are a couple of examples that I have here that are worth noting. I mentioned already, I'll kind of think of example 2 first, contamination fear during the early days of the pandemic. Well, we were rapidly and collectively trying to figure out what are the signals of our safety and what are not. The first example that I have listed here, this is one that comes up frequently for a lot of us when we are dealing with clients who might be concerned with crime. And if they're fearful of getting harmed, well, what does that mean if they live in an area where maybe the crime rate is a lot higher? And we have to really reckon with this problem because some of the safety cues that you might be inclined to eliminate could be really hazardous for the client. So we really have to kind of think more globally about it. The second example with the early days of the pandemic, to make this kind of feel real for all of you and the degree that it influences all of us, here's an example that I thought was really profound. And actually, this quote inspired a different study that I'm not going to talk about today that we did in our lab, again, during the peak of the pandemic. So this is a quote from an expert early in the COVID pandemic. This is someone who posted this online, but I won't name names. And the way it went is like this. I actually kind of paraphrased a little bit, so this is not an exact quote. But the person said, "There I stood on my porch washing my groceries while wearing a face mask with tears streaming down my face as I feared that it will not be enough, that I will still bring COVID into my home and infect my family. It was in that moment that I fully and completely understood what my contamination fearful clients go through every day, pandemic or not. And I wondered how I would ever go back to providing exposure treatment for contamination fear." So this concept of safety cues is one that we have access to and need to think about for ourselves as we consider ways to address this with our clients. And there's an interesting balance between the things that we're comfortable with in our own values around safety and what we want to convey to our clients. So elimination of safety cues, I'll leave it to you to think about how you would approach this, but just know that as you do it, it is fully in line with the inhibitory learning model. So you are conceptualizing things broadly along a dimension that is in keeping with modern exposure-based therapy. So exposure in multiple contexts, this is, again, one of those areas that I think many clinicians already do. If you're good at exposure and if your clients respond well to treatment, you probably have done this before. And here's how it goes down. So person has a feared stimulus, you do it in some specific context. So the context is things like their particular state of mind, a time of day, the way that they may feel, and you get fear reduction. Then you do exposure in a new context, no prior practice, and there's fear response. So they need to practice it again in a new circumstance. So practice in multiple contexts is what helps to ensure that there is durable fear reduction. There's a really clear example of this because the return of fear is an illustration usually of how the new context leads to a new response. If you're working with someone who has a fear of flying, you get them really good. Let's say if you're in the New York area, you're fearful of flying, you get the person to go to LaGuardia Airport. And if you've been to LaGuardia, it's a very specific context. And let's say I'll give you more detail for those of you familiar with New York. You're leaving on JetBlue, so you're going out of Terminal A. Terminal A has a giant rotunda. It's a very nice, kind of classic airline terminal, and you get on the plane. And let's say this is a great occasion. You're going to Hawaii. Now, if any of you have been to Hawaii, and let's say you're flying not to Honolulu, but you're going to Maui. So that means you're going to change planes in Honolulu. You're in the terminal in Honolulu very briefly, get on a different plane, go to Maui. Okay, get out of the plane, and then you're flying home directly from Maui. And I'm using this example because the Maui airport, the context there is completely different, not only because of it being on an island, but unlike LaGuardia and the Terminal A rotunda, I can assure you that at the gate in Maui, there will be chickens. Now, I know some of you are going like, wait, really? If you've never been to Hawaii, it's a wonderful place to go, and I highly recommend it. And an entertaining side thing is that in the airports, at the terminals, there are frequently chickens. There are also chickens wandering around when you go to the rental car place. But the point I'm getting at is that the context is sufficiently different. The presence of chickens, the presence of all the other stimuli associated with being in Hawaii is a new context, right? So we've often heard about this in the past as the return of fear, but we actually could think of it really as just simply a new context in which the person is experiencing a return of their flight fear because they never practiced leaving from Maui, where the prior experience in that setting is things like chickens and all the other attendant stimuli that are there at the Maui airport. Okay, so another one that's a little bit more likely to be experienced. I use my one with the flight fear. If you are working with someone who is fortunate enough to be flying to Hawaii, I'm sure you'll be happy to accompany them there to help them deal with their new context as part of your in vivo work with them. So contamination fear for medical waste, I'll use this as an example. This is an illustration of someone that I actually worked with. So the guy, very quick little clinical vignette, very fearful of medical waste and other things like it. His concern was that it will lead to neurological damage. At the time that I was working with him, I was at a place I was renting. So this is a very long time ago. I was renting from someone, and down the hall from us happened to be a medical lab. And I saw this guy for treatment at a time when the lab was closed for the day. So during the session, we walked down and stood in front of the lab, and right next to the door, at the time, the conditions for disposing of medical waste was a little different. There was like a small trash can with a lock on it, and that was where they, I guess they put out for medical waste disposal, someone that would come by to pick it up later. There would be this medical waste can. And we stood in front of the door barefoot. Now, what was part of this included were some expectancy violations. As you might imagine, standing in front of the door for a lab in a corridor in an office building with your therapist, and both of you are standing there barefoot, no socks either, just kind of wiggling your toes into the carpeting in front of a lab, little strange, definitely violates your predictions for how any of this would go down. So then afterwards, I had him go to some other places where medical waste concerns arose. One of them was pharmacies, and getting bandages at the pharmacy was a concern for him, not because the bandages were dirty, but because people went and bought them. And his assumption was maybe sometimes people go and pick these up while they're bleeding. Now, we know that that's not likely, but not outrageous. And so on the phone, I guided him through going to the pharmacy. Then his homework, again, if we're going for multiple contexts, he had to practice doing this solo in front of other labs. So he had to find, and we mapped it out in his community, where are some other labs that you can go to, where can you go to touch the doorknobs and stand there by the labs and be basically in touch with things associated with that. So that's the multiple context approach. Again, I believe very firmly that any of you on this line who have done exposure for any period of time and are good at it, you've probably done this. So another one is this variable exposure along the hierarchy. So in real world terms, you can't really pace yourself along the hierarchy. And so instead, what you might do is you start out working through the hierarchy with the client, but then afterwards, when you've mastered a lot of the items on the hierarchy, you will work on just kind of randomly presenting them in different order. So this is one of the, again, it's a little bit more of an advanced task, but it also resembles more likely the way the client will encounter the stimuli in the real world. So here we have, for example, a pretty basic illustration with spider fear. You start out small spider, house spider in a jar, elicits about a 20 on the SUDS. And then, maybe as part of treatment, there's also the house spider on the table and just freely walking around. And then maybe there's a tarantula on the table in a jar. So let's say those are 3 different items in sequence. But then for variable exposure, you start out with the one that elicits originally a 50, then you go to the one that's a 20, then you go to the one that's a 75. You kind of randomly mix it up. Again, this is one that needs to be done afterwards. But what's nice is that it facilitates new learning because there's a whole bunch of other circumstances that might lead to retrieval. So that concept of making sure that the learning is durable enough that the client can handle it in a random, almost like, I'm going to toss anything at you. It may be a little softball or it's going to be a fastball, but either way, you're equipped to deal with it. That's the intention with the variable exposure along the hierarchy. It's a more advanced thing, but it helps to really ensure the client has very firm fear reduction learning. Deepened extinction, again, I think it's one that you've probably done. Here's why I say that. So we've really been referring to things that are exposed as just stimuli. But we actually, for those of you that are, let's say, more experimental psychology minded, you know that the conditioned stimulus is actually a conditioned stimulus complex. So you could break anything that the person reports being fearful of into little tiny pieces. And so that means then if you really want to do deepened extinction, you break it apart into those little pieces and do exposure for each little chip of it. And then you do exposure for the thing in its totality. So that process of deepened extinction is where the assumption neurally is that there's a whole range of different little CSs that connect to a whole bunch of little CRs. And you're setting it up so that there's a whole bunch of new learning for all those little CSs. And then you bring it all home by saying, now the whole thing in one massive learning experience competes with that original CS complex. So like I said, you've likely been doing this for a while. Here are a few illustrations. So again, all of you on the line who are routinely conducting exposure, this is in your wheelhouse. We're giving some formal language to it. Contamination fear. So, you might have it where a typical routine for people with contamination fear, early exposure, is you have the person handle tissues that have been in contact with things that are otherwise considered fear eliciting. So you might have the tissue as a vehicle. It taps the trash can, and then the trash touches trash, then touches the receptacle, then maybe it touches a dumpster, and then finally, the person has direct contact with the dumpster. So that sequence for deepened extinction is handling this tissue that's been sullied in numerous ways as a build-up to the finale of, now stick your hands on the dumpster. Panic, we see this for a whole bunch of things. Interoceptive exposure for dizziness alone. So you spin the person around in a chair. Then shortness of breath, so you have them hold their breath. Then you have them do something that makes them sweat. Maybe do some push-ups or, run up and down the stairs. Then you integrate all of them by having them hyperventilate. Hyperventilation, if you do it well and you do it with enough vigor, will elicit all of those experiences. So that's deepened exposure. Spider fear, just to really bring it home, you could have the person go into the basement where it's well lit, there's no spiders. Then you go to parts of the basement where there's spider webs, but the spiders are not there. And then you integrate it by going to the basement in the dark, there's webs, and there are spiders present. That's deepened exposure. Again, I suspect that sounds familiar to you, and now we're putting a name to it. And what's nice about formally putting a name to it and describing it this way is that you can plan it accordingly, right? You can think about this as a conceptual approach specific rather than something that you've probably been doing implicitly but didn't have a name for. Okay, affect labeling. So affect labeling is where clients have a range of predictions, as we said before, from the expectancy violations perspective. And at the same time, when you do exposure, you probably, if you're asking them about their SUDS level, you ask them a simple thing, which is, how much distress do you feel? What we may not do as frequently is ask them, what is the emotional state that you have now? That's rather different. For those of you, again, that are more students of the full range of classical conditioning concepts, there's a bunch that are packed into this that are less well known. And one of them here is called evaluative conditioning. And evaluative conditioning is the process where a learned association, like conditioned stimuli to conditioned response connections, the individual names it. They give it a label. That act of labeling things tends to lead to that association being persistent. But what if the label that they have is an exaggeration or is incorrect, because when they do exposure with you, their experience is rather different? And you ask them to name it. So the affect labeling, where they explicitly say to you, oh, so I said I was going to feel this way, but now that we're doing it, I feel this way. That's a different kind of outcome. And it's really in line with a different movement that you probably have all heard about, but we don't associate with exposure, and that's emotion regulation. Emotion regulation can be incorporated into exposure through affect labeling. So it's an underappreciated facet to this, but it's, I think, a prominent one that we should really pay attention to. We're going to use affect labeling later. So reconsolidation is another one. Again, I think you've all encountered this before, and here's how it goes down. Person encounters their feared stimuli just a little bit before the session. It happens to also be the thing that you were hoping to work on during session. Now, when you go into the session, the consequence of being opportunistic in doing exposure for that thing actually facilitates fear reduction. So you can plan it instead of just waiting for it to happen, where the client engages in some pre-exposure immediately prior to meeting with you, and then you work on doing exposure with them for it during the session. So that process has the net effect of facilitating greater fear reduction. All right, so I'm going to illustrate that one too. So we have two illustrative cases. The first one, I like to start with this one. I've talked about this case in some other settings. This is a fun one to talk about, emetophobia. So those of you who are less familiar with emetophobia, it's a fear of vomiting. It can be a pretty serious and debilitating problem. It's an underappreciated kind of challenge for clients. So let's go through this client, a brief background. This is a woman who I treated myself. She was 34 when she came for treatment, not married. She was a member of a very religious community, and she felt a considerable amount of pressure to get married and have children. So by her age, when she was coming to treatment, she was pretty delayed in the course of expectations within her community. She was on no medication. She had a lot of prior treatment, mostly psychodynamic in nature. Remember, I'm a New York area psychologist. Psychodynamic treatment is the more dominant approach to therapy, even now in this area. She also had a brief course of energy therapy. So those of you who might be familiar with some other of these treatments, energy therapy, she specifically had meridian tapping. I won't get into details about that. If you're interested, talk to me some other time, and I'll be happy to offer you my opinions about some of these other approaches. She had some additional anxiety symptoms when she showed up for treatment. She had occasional panic that was below threshold for diagnosis. She was fearful of insects. In the New York area, you can be fearful of insects and not necessarily have it interfere with your life. And she had some, minor to moderate contamination fear, but again, not enough that would lead to an OCD diagnosis. Pardon me while I take a little sip of my beverage. Okay. She also had a lot of safety cues. She carried around with her anti-nausea medication. She engaged in a safety behavior where she would smell foods before eating it and would ask others to do so as well. She also kept air sickness bags on her at all times out of a concern that she might throw up. Um, and as a result of this, she avoided a lot of places. She avoided restaurants, bars, convenience store parking lots. If you live in an area with a convenience store nearby, like I do, and if you ever go on a Friday or a Saturday night, like I sometimes do, you know that occasionally what you might face in that convenience store parking lot is some local teen asking you to score them some beer. And because teens are not known for being able to hold their beer very effectively and also for drinking it in places where it's in public because they can't do it elsewhere, you might encounter vomit in the parking lot. And so that was something that she was aware of. Didn't encounter it that much, but definitely was aware. Um, she also avoided spicy foods. Spicy foods included like nothing spicier than ketchup, and foods that are more than a day old. So, most of us have food on hand that's more than a day old in their fridge. So these were some challenges. I should let you know I altered some of these details to protect the client identity. So it's a little bit of a mashup with some other clients. So the stimulus complex for Beth, not her real name either, by the way. A lot of vomit-related stimuli, vomit noises, babies. Any of you are familiar with babies, vomit is going to be there. Public bathrooms, parking lots, at nightclubs, feeling queasy. So here's just a few of them as examples, and this is a very abbreviated hierarchy, but it's for illustrative purposes. So the SUDS ratings here, we have some quiet vomit sounds, so like a little bit noise. Some videos of babies vomiting, being in presence of babies right in person, which, by the way, in her community, babies are around and easily accessible in her family. She worked in an office, so going to the public restroom there was an issue. She would sometimes struggle with the public restroom at the office where I was seeing her. Public restrooms at a restaurant, at a bar or nightclub where alcohol consumption and the inability to hold it down, those were issues. And then the physical experience of queasiness, that was maybe the highest level because that was the harbinger of potentially vomiting. So here were some of the ones that we relied on in the course of doing exposure for her. We disrupted expectancies. We conducted some procedures that were part of deepened extinction. We did eliminate a bunch of those safety cues. We did exposure in multiple contexts, so she had to go out and do some things in public. And we did have some occasionally reinforced extinction where she would specifically elicit for herself some mild queasiness. So there's some debate that's worth thinking about with emetophobia as to whether or not you must have the client vomit. My view on it is that it's desirable, but not a requirement. And the reason why is because vomiting is an evolved action. If you're unsure of whether or not this is true, think about a time that you were really stomach sick and whether you felt any relief from vomiting if you had like food poisoning, and you'll know that it's actually a good idea to be capable of vomiting. And so it's a good idea for you to have that as a skill. And so to me, it's something that people should learn how to do if they are fearful of vomiting. So here are some of the things that we worked on. We watched videos of animals vomiting. That's an expectancy violation. If you're not sure about this, find video of giraffes vomiting. It's completely bizarre and not like anything else that you're likely to expect when it comes to what it looks like or what it sounds like for vomiting. And so we practiced a lot of these things together. We did a thing where she listened on the other side of the door as I made vomit noises. This will be the comic relief section of our presentation. This is a case where I had this happen twice, where I made vomit noises as part of treatment. And if you have never done this before and you make enough retching noises, you will make yourself feel quite sick. This was the woman who I did this with her the first time. I thought I had it under good control. But what happened was at the end of that session, and we were out in the hallway rather than in my office. And she's like, "Oh, should we go back and I can pay you?" I'm like, "No, no, no. Let's meet next week." And because I knew what was happening for me internally, and it had a certain sense of urgency to it, she walked away, and I rushed back into the bathroom, and I actually vomited. Um, Sadly, I didn't learn the lesson of how to control it adequately because it happened a second time with a different emetophobia case. So just FYI, proceed cautiously on that. You'll be doing your own exposure for your own emetophobia at some point. Um, our deepened extinction approach, I had her practice the interoceptive exposure of queasiness. You can do that with some clients. It requires that you have them press firmly and repeatedly on their abdomen, and you can evoke some nauseous feelings. And then we had her separately listen to audio clips of vomit noises. We had she looked at photos of facial expressions just prior to vomiting, and then assembled those videos to watch videos of babies vomiting. So the culmination of it was to work on it that way. One of the safety cues that we eliminated was to practice leaving her anti-nausea medication at the office and then go to a restaurant. My office, when I was meeting with people in person, I don't meet with people in person any longer, by the way, for convenience sake, frankly. There are restaurants that are not too far away, and she was able to go. There was one that had the kind of cuisine that was in line with her religious practices. There were multiple contexts. She went to a restaurant during the daytime. She went to a restaurant with a busy bar scene, but during the day, she returned to each one of them on weekday evenings, and then ultimately to a weekend evening, right? So these, a weekend evening rather. So this is the multiple context facet. If you're not sure about how this goes down, if you go to some places where there are a lot of restaurants and there are offices around, during the day, the atmosphere is rather different than it is during the evening. And the restaurants near the office that I hang my hat in or have historically, the daytime scene is a lot of like business people locally coming in for lunch. But if you went out in the evening, it has quite a vibrant bar scene. So that kind of stuff. We had occasionally reinforced extinction. I did have her practice spitting up water and juice and some other mild liquids, but it really, I would not have counted that necessarily as let's say outright vomiting. To me, outright vomiting would be if she had to really, cough up something serious like a meal. And she did name her emotional experience throughout. So this was something that we did work on. As an aside, by the way, and this case for future training on imagery, I will bring this case up again because the imagery for this client was one that is in line with a different theme related to childbearing. And so I want to, for those of you listening to this and you're thinking about this case and the circumstances that led to her seeking treatment, it is not lost on me that there is a different stimulus element here that I have not discussed. And so I'm just going to leave that one for you. And I guess a little teaser for when the imagery workshop and training comes up. So, and Angela is sharing the vomit recipe with you all. Oh, and a little liquid cat food. That's a nice touch. So thanks for that, Angela. Okay, so just a little recap on how Beth did in treatment, and then I have one more case illustration, and then there'll be some time for questions. So at the end of treatment, Beth was doing great. She regularly goes to restaurants. This is a long time ago. I haven't kept in touch with her. Except from 6 months post-treatment, she was doing well. She was in a serious relationship and was engaged, which, again, kind of what she was aiming for as part of her treatment was to be able to more fully engage with her religious community. She was not in what I would consider conflict with the religious values that she was part of. Okay, so one more. Oh, whoops. So you know what? So I had changed my slides before this. I uploaded a prior version, and I had a second case. But I see that there's 20 minutes left, and rather than try to fight with coming up with my second illustrative case, why don't I open the floor up for questions so as to not, not delay us further. And I want to give people an opportunity to chat about some things and raise some concern. So if you want, for start, just put it in the chat. I'm gonna let me while we're doing that, I will close my slides. And where is my video? Turn off camera, turn. Okay, so I don't know if you guys can see me. It doesn't seem that you can. I'll put my slides back up on the screen so you can all see me. And so it's going to be back up. But go ahead and ask some questions and put them in the chat. We won't get a visual. You won't get to see me today. I dressed up for the occasion too. I have a nice hat on and everything. Questions from the audience? Type away. All right, so Angela is asking a question. So would we have reached the inhibitory learning model more quickly if we stayed closer to tight behavioral principles? And that's a good question. So I think that it is likely the case. I think about in the history of learning theory research, the trajectory is one where people, I guess, were more romanticizing about the role of CS exposure as Pavlov described it and maybe was not translated accurately. But if we really look at the trajectory of some of the basic research, an example that comes to mind is the research that Rescorla did. So Rescorla in the late 60s and early 70s was talking about how different ways in which the conditioned stimulus is presented to somebody, especially prior to the learning experience, sets the stage for the way in which that CS and condition response association is formed. Now, if we kept following that trajectory, and then also at the same time, the basic research that I cited earlier by Robert Bowles that highlights how expectancies form, then we might have gotten to it a lot faster. You're right. And then the other thing, I frankly don't know what the intervening events were between FOA's lab's own research on exposure in 77, where they demonstrated that you did not need to elicit fear. I don't know what happened between that study and the conceptual paper that they put forth in 86, but there's some intervening event that led to FOA and Kozak and others in that group to change their thinking around how exposure should be conducted. And so, yeah, I think we could have gotten here faster. And I also think that maybe the reputation for exposure would be a little different with respect to, the concern that's in the public eye of, oh, you have to feel fear. And I think in some cases for early developing therapists who take the message of the FOA and Kozak model to be accurate, and they implement exposure in that spirit, but then on the flip side are unable to recover from it when clients feel undue levels of fear and struggle with participating in treatment further. So it's a complex matter, but I really do feel that most clinicians actually inherently do a lot of these things. And it's nice to have a formal model now that we can talk about. So thank you for that. And thank you, Fred, for your compliment. Other questions or comments? I'm eager to hear from you all about this. It's a very detailed model, and I hope that you're able to think of ways to apply it in cases. But I'm eager to hear from other folks with some questions. All right, so let's see here. So Fred, I'll start there. We have two questions here, so thank you. So one is, to what extent does it really represent current practice in the field? I can see many aspects of exposure employing ERP being applied, as you noted, often naturally, but the habituation model is still used in most practices, my impression. Yes, so you're right. I think so. There are two parts to this. So one, I think you're right that exposure treatment, and if you look at some things that have been written by people who practice exposure in treatment guides for clinicians. The one that I remember very clearly, Jack Rackman would talk about exposure prior to him becoming more cognitively oriented later in his career. Jack Rackman would talk about exposure in social circumstances and exposure for social anxiety, and it would be involving a bunch of very silly kind of things that would elicit laughter, things with wearing a hat and doing things that are kind of goofy as part of it. And to me, that's not really exposure if you think about what it's eliciting, but it does have the elements of here's the conditioned stimulus and we're bringing about some new reaction. Um, I think the habituation model probably is still used in practice in some conditions, most notably, I think, with respect to trauma. This is where you probably see it the most widely used as a pure habituation approach. Um, and this is, again, this is anecdotal, what I'm saying. So my point about it being what I think is the clinician model, I'm saying that anecdotally, and I'm also saying it in the context of what, again, in the category of just stuff I think, as opposed to stuff that's known from survey and other data. My sense is that if you're going to be able to really sustain treatment with clients where your task is to elicit fear in session, there has to be also in your pocket some strategy to help the client know that they can come back and be able to experience this without it being unduly aversive. And so that balance is a hard one. And I think where we see it the most as the most challenging is in prolonged exposure for trauma. Prolonged exposure for trauma is one where, expectancy violations are harder to come by. The one that I think is useful, or at least the most useful, is in using affect labeling. So I'll do a little plug. This will be a Dean McKay plug, if you will. A student of mine, a former student of mine, Brandon Frank, he and I co-edited a special issue of Cognitive and Behavioral Practice. And so one of the articles in that special issue, it came out in 2019, the whole issue was devoted to inhibitory learning approaches. And one of them related to affect labeling specifically was by Lori Zollner and her group, where it was all about the applications with trauma. And so affect labeling is a useful one. And I think, again, it's one where you can walk a little bit away from purely habituation. And I think it facilitates keeping people in treatment a little bit more. So there are several more questions. Thank you. Angela asks as a follow-up, how often do exposure therapists think about contingencies that maintain fear or fear-related disorder conditions that extend far outside of simple accommodation? So the example is cases coming in for treatment. They meet criteria for OCD, but it's been very reinforced to talk about symptoms and the like. So in the category of like, what do clinicians do who are very effective? And when I've consulted with clinicians in the past, contingencies need to be discussed. Contingencies including things like how much reinforcement is there to be in session, and what is the actual session eliciting. So you ask the client, hey, how are you doing? There's a case that I could think of where this specifically applied. Outside of the session, the client was doing much, much better. But because when they entered the clinical room, the room itself was like a cue for depressed mood, apprehension, anxiety, and it was basically a fear reacquisition activity. So much so that I started meeting with them in different offices in the building. And then I said, okay, we should start meeting remotely. This is before we were doing, before I was doing only telehealth treatment. So I think we have to think about a whole range of things that we're not accustomed to doing. Like, hey, wait a second, my office is a specific cue for fear. Well, maybe, and we should think about that in the broadest sense possible. And it leads then to exposure in multiple contexts and really kind of thinking more broadly about all of the contingencies. So contingency learning is great. Um, so a couple more questions here. We have a little bit more time. Thank you. So Michelle's asked a nice question about the role of medication and as a safety cue, and whether it's humane to have flyers use these things as a safety cue. And I think so. Medication, I do think, is a useful one to fade out as a safety cue. Ultimately, with flying, there are so many safety cues that people rely on, and there are many people who do so, and you may face a conflict in the course of treatment. I've worked with some people with fear of flying, and they've come to this resolution of, yeah, you know what, I'm good with what I've accommodated to. I can fly comfortably, and I just need to take a single Xanax before I get on the plane, or I need to know that I have one with me. And so I'm not likely to be able to get past that. Um, and the widespread nature of fears around flying and the safety cues that they include, um, nothing speaks louder than the fact that at every gate area there's a bar. And so, we know that people rely heavily on these things, and we need to really think carefully about how to help clients get past that. Um, and so I would encourage to still try to eliminate it as a safety cue. I don't think of that one as a particularly adaptive one. There are plenty of other safety cues that are adaptive, right? If you're on the plane, uh, and the pilot or some other person says, "Hey, we have to pause because there's an equipment issue," uh, don't be the one yelling like, "What? Why are we not getting off the ground?" That's a safety cue that you want to have firmly in place. Get off the plane, fix that thing, get back on. But these other ones like medication and the like, I do encourage eliminating those. Um, okay, so the last one I have on the list here so far, and there's time for other questions to get put out there. What are my thoughts on providing psychoeducation or cognitive strategies prior to exposure? Do I think this can either can it reduce the potency? Um, so I guess it's two parts then. Psychoeducation is important, and as part of that, it's important to inform clients of what treatment's going to entail. So, in my view, education is an absolute requirement. Now, that's separate from cognitive strategies. Cognitive strategies uh, come in two varieties, really. So, you can have cognitive strategies that are meaningfully and conceptually connected to the presenting symptom. And then there are cognitive strategies that are potentially interpreted by the client as reassurance. So, to illustrate a distinction, and I'll use OCD as an example because the cognitive model for OCD is well developed in a way that we can think of it as not providing reassurance. So here's how it might go. Client comes in, they say, well, I have concerns about thoughts of harm. Exposure, you might have them do things like when I was doing this in person regularly, I always had a steak knife in my drawer. Person's worried about harming someone. uh, Education wise, I would inform them that a naturally occurring process in OCD is that people assign great importance to their thoughts. And so if you have a thought of harm as an OCD sufferer, you may translate that to mean, therefore, having the thought makes it very important that I pay attention to it because I might act on it. Now, I give them that information. That's all I do. I'm still going to hand them the steak knife. I'm still going to make noises in the office like, hey, why are you threatening me with that knife? Oh, ow, why are you stabbing me? And I'm going to say things that are in line with exposure, and they will probably also violate their expectancies as I'm telling them that they're stabbing me and that, they pluck my pancreas out or whatever. Um, and so I don't see those operating at odds with each other. Now, on the other hand, a cognitive strategy that is, let's say, a la the original model of cognitive therapy for things like depression and other mood problems would include things like verification of information. Like, what is the evidence that you're maybe going to stab Dean while you're in the session with him. That I think that would definitely be an undermining strategy. So the distinction is a finer one, but it's a good question because we do wrestle with this because sometimes that cognitive strategy, so even the overimportance of thoughts, could be problematic. Oh, okay. And so thank you for the clarification, Catherine. So, um, yeah, psychoeducation for cognitive distortions, thought action fusion, telling people about thought action fusion doesn't change the degree that they struggle with it when you violate it. Now, if you're not sure about that, thought action fusion, that's a great example to yoke to this discussion. And I appreciate that you feel it clarified, but I'm gonna stick the landing a little bit harder on this still. So thought action fusion is the one cognitive distortion that we as behavioral and cognitive therapists run against the public grain. If you don't believe me, look no further than the widespread popularity of the book The Secret, which is predicated entirely on teaching everybody to embrace thought action fusion, but for the positive side. And I've done this with clients where I'll say, okay, here's the process. People with OCD struggle with the idea that if I think something, it increases the likelihood of it happening. Okay, and so that's what you're struggling with. OCD is telling you, if I think it, it will happen. And so now let's practice that. So I tell them point blank, here it is. We know what it is. We've all heard about it. And now that you're sitting in my office, let's wish for the garbage can to just go up in flames. Or what I tell people a lot, and people get very uncomfortable when I talk about this, I have prayed, not just wished, but prayed with clients for whom I know I'm not offending them religiously. I have prayed to be in a fatal car accident for myself from the time that I end the session to the end of that day. This is again back in the days when I was seeing people in person. And I would say, watch the news reports, see whether or not there's a fatal car accident somewhere around exit 30 something on the Long Island Expressway, or anywhere along that route. I would tell them basically my route. And I'd say, watch to see if there's a fatal car accident somewhere between 7:30 and 9. And remarkably, I've not died yet in a car accident. And so that concept would nevertheless create discomfort even when they know about it. And so I find it a fascinating thing and it's useful because, again, if the conditioned stimulus elicits the fear, it's going to elicit the fear. But we don't want to develop for the person some way of undermining it. So thank you. It's an excellent question. It comes up very frequently. So I see that we're just about out of time, and so I guess I probably could entertain one more quick question. So if you have a really quick one, drop it on me. And if you don't, I will drop into the chat my email address for you all. You could feel free to drop me a note if you wish to follow up. So I'll make a concluding note or two. So again, thank you all for coming. And I know some of you may view this as a recording later. This is my first training offered as part of my developing and very nice partnership that I'm excited to be engaged in with Better Living. And so I'll look forward to seeing you at future trainings. Angela and I have several more lined up in the coming months. And so keep an eye out for those. And thank you, everybody. Thank you for the great questions. And look forward to seeing you all out there. I think I'm not on video. If you've seen me the whole time, great. So I have not seen myself, but I've been chatting away. Thanks, Angela.